Hello dear friends, today we'll be seeing the radiology section. As usual, we are going to visit this site www.aappg.net, and you can see the whole extension. And let us start with the questions. A neonate presents with respiratory distress and contralateral mediastinal shift and multiple cystic airfill lesions in the chest. Most likely diagnosis is. Here you can see four options. First, if you think this question is difficult, let us rule out some options. A neonate presents with respiratory distress, contralateral mediastinal shift, and multiple cystic airfill lesions in the chest. So first thing, option D, none of the above, usually is not the answer. Option C, pneumonia. You can see that neonate presenting with pneumonia usually doesn't present with mediastinal shift, because you should know that there are reasons for mediastinal shift. If it's to the contralateral side, either it's a pneumothorax or it could be a pleural effusion. If it's a shift to the same side, it should be a collapse. A consolidation usually doesn't shift the mediastinum to any side, usually. So ruling out pneumonia, you just have two things to rule out. The first thing is, now you have a 50% chance in guessing. So let us go. The clue here is contralateral mediastinal shift. Congenital lung cysts do not present with mediastinal shifts. So the answer will be congenital diaphragmatic hernia. There are many other MCQs that you should know about. Congenital diaphragmatic hernia is a very high yield topic both for your MCI screening test as well as your DNB and your NEET PG. You should know about Bogdelax hernia, Bosch-Delax hernia. Then you should know about the presentation, and you should know that the bag and air ventilation is contraindicated. Apart from it, I think you will be able to manage any other questions. Let us move on to the next question. Ground glass appearance is not seen in A. hyaline membrane disease, B. pneumonia, C. left to right shunt, and D. obstructive TAPVC. Now first thing, ground glass appearance, I think everyone knows that hyaline membrane disease shows ground glass appearance. You should pneumonia, many of you will be thinking, does not show ground glass appearance, but he hasn't mentioned which type of pneumonia. Ground glass appearance does appear in any interstitial pneumonia, for example by chlamydia or influenza. You can think of any reasons. I have opened a specific site for this. You can see the extension here, path HSW5M54. It's a funny site. You can find it out by googling it on net. You can see the basic HRCT patterns and ground glass opacities, and you can see here this patient had influenzaal pneumonia, and then you can go down and you can see that common causes include ARDS, viral, mycoplasmal. Of course he has written for adults, but it applies to the children as well in this case. So pneumonia does show ground glass appearance. The two options here are left to right shunt and obstructive TAPVC. You should know what is TAPVC before going on to ruling out the options. TAPVC stands for total anomalous pulmonary venous return, TAPVR. So here you have what it means is, here is a picture of it. There are various types. As you can see, there are 4 pulmonary veins, and then they drain into the left atrium normally, carrying oxygenated blood from the lungs. Instead of draining into the left atrium, they drain the total pulmonary venous drainage drains into something else. It could be supracardiac, and it could drain by a vertical vein joining it, and it drains into the right atrium via the superior vena cava. Or it could be cardiac. Supracardiac is the most common type. Or it could be cardiac, where it joins with the coronary sinus, as you can see in the diagram. It could be infracardiac and join with inferior vena cava below the diaphragm. It could be a mixed type. You can see it better in a different diagram again. I think this is a better diagram. As you can see, the pulmonary veins, and there's a vertical vein which is joining with, and finally it joins the brachiocephalic, and finally it joins to the superior vena cava and drains into the right atrium instead of the left atrium. This one here shows an ASD also present in this diagram. This shows the same thing. So in an obstructed TAPVC, due to the pulmonary hypertension, you do see a ground glass appearance. The left to right shunt like VSD and ASD, you're going to see a plethoric lung field. You're not going to see a ground glass appearance. Moving on to the next question. Drug that is radioprotective: A. Paclitaxel, B. Vincristine, C. Amifostine, and D. Etoposide. First, you should know what he's talking about. If you have this book called Sure Success Magic by Dr. B. Ram Gopal, it's a very useful book. You can move on, you can see the chapters on radiotherapy and radiology. He has given different chapters. The last pages in radiotherapy, you can see that he has given about radiosensitizers and radioprotective agents. This question has been repeated many a times, so you should know. You can see radioprotective agents are agents which protect the cell against radiation, against the toxic effects of the radiotherapeutic drugs or radiotherapy. So amifostine is a drug which is a radioprotectant. There are other drugs. I remember them by the mnemonic PACE, named after Leander Pace, but it's PAEZ, and P stands for pentoxifillin, A for amifostine, E for etramastin, do not confuse it with etoposide, and Z for zinc oxide. I'll repeat: PAEZ, P for pentoxifillin, A for amifostine, E for etramastin, and Z for zinc oxide. These are the radioprotective agents. The names of these agents are given on page 689 in Sure Success Magic. You can find it in many other books as well. The other options given are radiosensitizers. What it means is, you should know a basic concept that any hypoxic cell is resistant to radiotherapy. You need more dosages of radiotherapy to kill a hypoxic cell. So what they discovered is, they discovered few drugs which can sensitize these hypoxic cells. They sensitize these cells to the effects of radiotherapy. So the most commonly used drugs, they are divided into various classes. Hypoxic cell sensitizers, most commonly like metronidazole, nimorazole, misonidazole, the nitroimidazole group basically. What it does is it mimics the action of oxygen inside the cell, and hence it produces the same toxic effects. Even though the cell is hypoxic, it acts as if there is oxygen inside the cell. There are other agents like non-hypoxic cell sensitizers, bromodeoxyuridine, iododeoxyuridine. All these you can find in that single page 689 in Sure Success Magic. There are other agents, chemotherapeutic agents, molecular targeted agents. The basic principle is, a radiosensitizer is going to make the cell susceptible to the effects of radiation. For example, paclitaxel, paralyzes the microtubules. So after the effects of radiotherapy, the cell cannot repair itself, and hence it will die. So be sure to remember amifostine, and be sure to remember the mnemonic PACE, PAEZ, and you'll do fine in the questions which are about radioprotective agents and radiosensitizers. Moving on to the next question. Most radiosensitive tumor of the following: carcinoma kidney, carcinoma colon, carcinoma pancreas, and carcinoma cervix. Among the options given, carcinoma cervix is the best answer. This too you can find in that previous page in that book, Radiosensitivity of Tumors, but I would suggest you learn the bigger table in Harrison, which gives you distinctions of highly sensitive tumors, highly radiosensitive tumors, moderately radiosensitive tumors, relatively resistant tumors, and highly resistant tumors. And the most usually asked questions are Regarding highly radiosensitive tumors, you can remember them by the mnemonics WELMS, W-E-L-M-S, W-E-L-M-S. W stands for Wilms tumor, E for Ewing sarcoma, L for lymphoma, S for seminoma, and M for myeloma. Not melanoma. Melanoma is radio resistant. You should remember this. You should not get confused in mnemonics. W for Wilms, E for Ewing's, L for lymphoma, M for myeloma, and S for seminoma. Okay, thank you.